Ed yesterday kicked it off with a great presentation introducing COVID-19, focusing on the epidemiology and some of the physiology as well. We're going to take a slightly different tack today, and the title of this talk is Breathing Basics, A Guide to Respiratory Terminology. So as Blair said, I'm James. I'm one of the intercalated medical students. I'm based up in Leeds, and I've been in the emergency department here for the last 6 months. And that's where we've put together these resources we're presenting tonight. So what we're going to do is try and explore some of the key respiratory physiology that's relevant to understanding both the disease process of COVID-19, but also some of the treatments and management strategies that are used with these patients. I know we've got a mixed audience of medical students, nursing students, paramedic students. So for some of you, this will be stuff that you've seen before and revising with a more clinical spin. And for others of you, this might be new. And what we're going to do is really focus on the stuff that's relevant to understanding COVID-19, because respiratory physiology can get scary quite quickly if not. And hopefully what you'll find is that with the foundations we put down today, tomorrow the talk from Glenn on ARDS and the 2 talks on Tuesday on oxygen therapy and CPAP will really start to make sense, and you'll understand the principles behind some of these interventions. So Blair's mentioned before, our charity, will put that link up again for you at the end. And just a reminder, I know Blair touched on it before, that this series aims to introduce some of the fundamental concepts relevant to COVID-19, including the underlying physiology and clinical management strategies for COVID-19 patients. However, the presentations are not designed to provide guidelines or definitive clinical advice. They're based on the current best knowledge, but COVID-19 is a very rapidly evolving field. Respiratory physiology maybe less so. Always please follow your local guidelines and recommendations, and the presentations do not reflect the opinions of the contributing institutions. Okay. So let's kick off. So we're going to try and do 4 things in this short session. We're going to start with some terminology and try and distinguish the terms breathing, respiration, ventilation, perfusion, and oxygenation. It's terms that are sometimes used interchangeably, but all have their own specific definitions. We're going to recap and understand the normal mechanical process of breathing, recognise why both ventilation and perfusion are required for respiration to occur adequately, and we'll talk about those definitions before we go any further. And then hopefully this will help you to develop an awareness of some of the interventions that we can use to optimise those components of respiration, so that when we look at them in more detail in the subsequent sessions, you can understand why they work the way they do. So let's start with some terminology. These are the kind of 4 key terms that really you want to try and take away from today. The first term is oxygenation. So oxygenation is an overarching process that involves the addition of oxygen to the body system. So that's taking oxygen from the ambient atmosphere around you and delivering it to the tissues, to the organs that need that oxygen for processes happening in those cells. Okay. Oxygenation is dependent on several processes, and the ones we're going to focus on are the respiratory processes. So that is the process of respiration, which is the process whereby gas is exchanged in the lungs so that oxygen can enter the blood. And respiration depends further on 2 components, and that is ventilation and perfusion. There's a nice diagram that shows this in a minute, so just hold on while we go through these definitions if you want to sort of see this a bit more visually. So ventilation is the movement of gas in and out of the lung, in and out of the airway using pressure, and perfusion is the supply of blood to the capillaries, and today we're saying perfusion to the lung. So you might hear people talk about perfusion of organs, perfusion of tissues, but when we say perfusion today, we're talking about perfusion to the lung. And what you'll find is that ventilation and perfusion are required together in order for respiration to take place. So take a second, look at those definitions. We'll come back to them as we go through. So let's talk about oxygenation. So that's delivering oxygen to the tissues. Oxygenation is a 2-step process. Step 1, we've got to oxygenate the blood in the lungs by taking oxygen from outside the body and moving into the blood. And step 2, we've got to deliver that blood to the tissues that need the oxygen. Okay, so it's pretty simple, but think of it as 2 components. And we can see that visually on the next slide. So you can see, like we said, and I'm labouring the point a bit here, but oxygenation is that overarching process that depends on respiration, which is getting the oxygen into the blood, and then you've got to deliver that blood to the tissues. Okay, so any failure in oxygenation, so a patient who is hypoxic, you can attribute to either a failure of respiration, which is this part on the left-hand side, or a failure of circulation. So when you have a patient who has low oxygen saturations, it's quite nice to try and break it down and think, is this a respiratory problem or a circulatory problem, or is it a combination of the two? So for that respiration, as we said, you need ventilation and perfusion, and we will expand on both of these terms as we go through. We're going to focus more today on ventilation because that's most relevant in COVID-19, but I'm going to signpost you to some other resources at the end that kind of talk more about perfusion and the idea of ventilation and perfusion and the matching of those two components. So let's take a deep dive into some anatomy. So if you go down into the lungs, the end unit in the respiratory tree is of course the alveoli, which is where gas exchange takes place. And the way that respiration takes place there is that you have ventilation of air through the bronchioles into the alveoli, and then you have the blood being perfused from the right side of the heart through the pulmonary arteries and into the capillary beds that sit in the alveoli. And we're getting the mixing of air close to the capillaries, and that's what's going to allow the respiration to take place. So for the rest of the talk, all we're going to do is focus in on these alveoli because that's what we're really interested in. So I spent some time this afternoon trying to work out where this diagram had come from, including going on Google reverse image search, but I couldn't get anywhere, and that's because it is an original illustration by Glenn. It demonstrates the point that we're about to talk about really well, actually, which is that this process of respiration, as we've said, is dependent on ventilation of the lung and perfusion to the lung. So ventilation being the movement of air, perfusion being the movement of blood. Failure in either of these is going to impair respiration. Okay, so why might ventilation fail? Well, if a patient who's been breathing hard with a high respiratory rate starts to tire, then they might not take as deep breaths, and they might not ventilate air in and out as well as they were before. So you get a failure of ventilation. Why might perfusion fail? Well, if you've got a big blood clot, so you've got a pulmonary embolus that's blocking blood in the pulmonary artery from getting to the lung, then you would have a failure of perfusion. So what you need for respiration to take place is good ventilation and good perfusion. If you have one of these components on its own, you won't be able to get the mixing, the ventilation of air into the alveoli, and then the movement of the oxygen across the alveolar wall into the blood vessels where the blood's coming by perfusion. Okay. So all of the strategies really that are being used to manage patients who are really sick with COVID-19 relate to improving either ventilation or improving perfusion. So a really good example of that is proning patients, so turning them on their front. We won't talk about that much today because we'll come back to it in a later session. But what proning does is it aims to improve the ventilation and really significantly aims to improve the perfusion to the key aspects of the lung so that you can get better respiration and therefore better oxygenation of the tissues. Okay. If you've got any questions as we go on, please do post them in the chat. The other guys are looking at that as we go too. VQ mismatch, briefly touched on there, but I'm not going to talk about loads in this presentation, but I've got some resources at the end that I will show. So we've talked about ventilation, we've talked about perfusion. Let's focus on ventilation for the next few slides. So ventilation is the movement of gas through conducting portion of the airway, you should say, and it's done by exploiting different pressure gradients. So the easy way to think about this is to think of the lung as a big set of bellows, and we're going to talk about how those bellows can work in different ways. And ventilation, kind of think of it as taking place in one of two ways. So hopefully you are sitting at home breathing. So that's the normal way in which ventilation takes place. But obviously for some patients who are critically unwell, we might take over their breathing for them, and we might use mechanical ventilation instead. And there's some really key differences between these two processes that I want to highlight. So breathing, the normal process of ventilation, is initiated by internal changes in pressure. So we'll talk about how that happens, but essentially you increase the volume of your chest, that increases the volume of the lungs and lowers the pressure in the lungs, and that draws the air in from outside. So it's an internal process that relies on negative pressure. So breathing is an internal process that relies on negative pressure. By comparison, if we are ventilating a patient, either through a tube in their airway or with a tight-fitting mask, then that's an external process, and we're forcing the air into the lung. And this is positive pressure ventilation. Okay, this explains why being on a ventilator can have damaging effects on the lungs in terms of trauma, barotrauma, and it also explains partly why it can be difficult to wean people off ventilators. So the key take home from this slide is breathing is an internal process that relies on negative pressure, and mechanical ventilation is an external process that relies on positive pressure. And this is a really interesting picture on the right. It's taken from an intensive care unit in Wuhan in China. And you can see here there's a patient who is probably on an NIV mask, so they've got a tight-fitting face mask on here. And the two healthcare professionals looking after them in PPE. I'm not sure what they're doing, but you can see that the patient is connected up to the ventilator that's probably on the left-hand side here. So that's providing external positive pressure ventilation. Okay, so we talked a bit about the differences there. Let's go back to breathing, and we'll talk about lung volumes in ventilation. And again, there's some key take-home points here that are relevant to COVID-19, but just bear with me while we get to them. So when you breathe in and out normally, you're actually not using much of your lung at all. You're just using a small proportion of that. So just focus for a second on your breathing. Try and breathe normally. This is an interactive slide. And what you're doing there is you're probably taking small breaths in and out each time you breathe. And we call that your tidal volume. So that's the normal breath you take in and out. And for the average reasonably sized adult, that's probably about half a litre of air in each breath. And you can see in the left area, I don't know if you can see my mouse or not, in the left area on this graph, the tidal volume here. Okay. Tidal volumes are important because when you set up a ventilator, it's one of the parameters that you define for your patient. And in ARDS, which Glenn will talk about tomorrow, one of the strategies that's used to reduce trauma to the lungs is to use smaller tidal volumes. Okay. If you can take a really deep breath in now and hold, and then you can breathe normally, what you've done there is you fill your lungs up to their full capacity, probably 5 or 6 litres, and you've used your inspiratory reserve volume. Okay. And if you now breathe out and breathe out all the way, and hold, and then you can breathe normally. So what you've done there is you've used your expiratory reserve volume. Okay. Breathe normally now. I don't want anyone holding their breath at the other end. So you can see that actually the tidal volume is that normal breathing in and out, and then we've got these reserve volumes on either side that we can use. Okay. Obviously volumes up the left side here. Somebody's asked a question about what causes damage, so we'll talk about that in a later presentation more, but tidal volumes, small tidal volumes, are one strategy that can be used to reduce damage on a ventilator. There is obviously going to be a little bit of your lung volume that you don't ever exhale, because you can't, no matter how much you exhale, you can't turn the volume of your lungs right down to 0. And that's the residual volume, or the dead space that sits within your lung. So if we move to look at the right-hand side of this diagram now, sorry about that, I hope you got the right side. What we've got here is capacity. So capacity simply is a sum of multiple volumes. And while there are lots and lots of capacities, there's one that I want to highlight here, and that's the functional residual capacity. Okay. Sorry, it looks like my slides are jumping. So the functional residual capacity is simply the sum of the residual volume and the expiratory reserve volume. So that's the portion of air that's left in your lungs while you're breathing in and out normally. Okay? The reason the functional residual capacity is important is when a patient is being intubated and they have COVID-19, there's a real risk of them desaturating in that time, because using a bag valve mask to ventilate them is something that can't always be done because it's an aerosol generating procedure. And if you look at some of the reports that's coming out from these patients, people are saying that they drop their saturations a lot during that process. So pre-oxygenating the patient, giving them supplementary oxygen before that procedure, will take that functional residual capacity, the air that's left in the lungs, and rather than it just being normal air, you can top it up with oxygen so that it's not quite 100%, but getting close to that. And that means that the patient is less likely to desaturate in the period where they're having their intubation. Functional residual capacity is the anaesthetist's best friend, really. Okay. So tidal volume and FRC, two things to take away. While we're talking about normal breathing, we'll just recap the process of normal breathing. And the key thing to remember here is that inspiration is normally an active process and expiration is normally a passive process. So we'll just talk through the mechanics of this. So when you inspire, when you breathe in, the diaphragm that normally sits up into the chest will contract, and that will cause it to flatten down. And the muscles in the chest wall, the intercostal muscles, will contract, and that will lift up both the ribs and the sternum. The result of that is that the volume of the thoracic cavity increases. And because you've got the pleural seal around the lung, between the lung and the thoracic wall, the volume of the lung will also increase. If you think of that lung as a closed box, you can see with this diagram on the right that when the capacity increases, the pressure in the lung will decrease. And this will cause that air to rush in through the airway into the lung. So that active process by contracting those muscles will result in inspiration. Okay. Normally, expiration is a passive process. So the diaphragm relaxes and rises up, as you can see. The external intercostal muscles relax, and then the weight of the thoracic cavity, thoracic wall, the ribs and the sternum, that pushes down as well, and the size of that box decreases. And as you can see, the pressure as a result is going to increase within the lung, and that's going to just push the air out. Okay. So inspiration, normally an active process. Expiration, normally a passive process. This can change, and we're going to introduce the concept of forced breathing. So forced breathing is something that happens when people are breathing under stress. That might be because you've gone out for a run on your daily government endorsed exercise allowance, or it might be because you've got some sort of respiratory pathology going on. Okay? So forced breathing involves a number of things. It involves the use of extra muscles. It involves rapid changes in the thoracic cavity volume, and it introduces an active element to both inspiration, as normal, but also to expiration. Okay. It's still negative pressure ventilation, but there's an active element to both breathing in and out. So when you breathe in, you'll start to use some of the muscles in your neck and your shoulders, like scalene, sternocleidomastoid, pectoralis muscles, serratus anterior, lat dorsi. And then when you expire, that normally passive process uses muscles to force the air out, and that allows you to breathe quicker and to shift bigger volumes. So some of the other intercostal muscles are involved in that process. The best way to think about active expiration is to think about inflating a balloon. So if you put a balloon on your mouth and you try and breathe into it passively, you won't manage to inflate the balloon. You've got to push that air out, and that's active, it's expiration. So forced breathing is something that you can visibly see, and patients with forced breathing show signs of respiratory distress. So you will see they might be tripoding, they might be using those accessory muscles in their neck and shoulders. If you Google a video of respiratory distress and accessory muscles, you'll find some nice examples on YouTube. But this might indicate that the patient is hypoxemic. So this is an important thing to look out for and identify early. And often you don't need a SATS probe on someone's finger if you can see that they're obviously in respiratory distress through this forced breathing. One of the interesting points about COVID-19 that's coming out, and I don't know a huge amount on this, but certainly I've seen it reported, is that often patients with COVID-19 have low saturations, but actually don't necessarily have these signs of respiratory distress in the early course. We were talking a bit about this yesterday, and I think one of the theories is that patients with COVID-19 primarily have a problem with low oxygen levels rather than high carbon dioxide, so they have a type 1 respiratory failure picture. And that means that their oxygen levels can drop quite low before they start going into this respiratory distress and having to do forced breathing. Just to wrap up the physiology then, there's two more things we're going to talk about. The first is airway resistance, because this is relevant as well. So the resistance of your airways is the main factor that determines how hard you have to work to breathe, to move and ventilate that air in and out of your lungs. Okay. There are a number of factors that influence airway resistance. So airway resistance will increase if you have a smaller tube, if you have a longer tube, and if you have disrupted flow through that tube. So the really easy way to think about this is to think of a cannula, and you all know that the big orange cannula will put through much more fluid in a fixed minute, for example, than a tiny little pink cannula. And that's an exponential difference. So for every increase in the radius, the increase in the flow rate is by a factor of a power of 4. So it makes a huge difference. And this is why when asthmatic patients get bronchospasm, their airway diameters decrease. They have to work really hard at the breathing because the airway resistance increases so much. So a longer tube, so a longer giving set for our cannula, or in the case of a ventilator, a longer tube, that increases the resistance too, so you'd have to use more pressure to get the air in and out. But the big problem is this turbulent and laminar flow concept. So if you have nice parallel flow of air, the resistance is quite low. But what happens is when there is resistance around, that air becomes turbulent and disrupted. And the problem with this is when the air does that, it generates even more resistance. And this is why airway resistance is such a problem, because once it starts, it can increase because of the turbulent flow even further. You'll see signs of that increased airway resistance in a patient who's breathing because their work of breathing increases because they're having to forced breathe. And this puts them at risk of tiring out. And in a mechanically ventilated patient, they may require higher pressures to shift that air in and out to ventilate. Okay. Things that can be done, for example, is suctioning secretions, and on intensive care, there's quite a big focus on these sort of things because we know that airway resistance can be a big problem. And if we minimize the amount of pressure required, then the risk of trauma to the lung and things from the ventilator is reduced. Okay. The final concept we're going to talk about from a respiratory physiology perspective is the idea of gas exchange and the oxygen cascade. So this is about how the concentration or the partial pressure of oxygen changes as we go from the external environment through the lung and to the tissues and the cells where that oxygen is required. So partial pressure, if it's a new concept to you, it's the pressure of a gas, but as times by the percentage that that gas makes up of the air. So the ambient air pressure around us is 100 kilopascals, but because only 21% of that air is oxygen, the partial pressure of oxygen is 21 kilopascals. Okay. So you can change the partial pressure by changing the percentage that the gas makes up, or by changing the overall pressure in that environment. So in ambient atmosphere, the partial pressure of oxygen is about 21 kilopascals. And actually what this diagram shows is that by the time you get down to the cells, that's decreased right down to 1 or 2. And that happens in a number of steps. So when you breathe oxygen in your nose and your mouth, that air that you're breathing in, is humidified. The impact of that is actually you reduce the proportion of that's oxygen, and so the partial pressure takes a little bit of a hit here, you can see. By the time that air gets down into the alveoli, it will have mixed with air that's coming out, and the partial pressure of oxygen has already dropped right down to 12 or 13 kilopascals. The next step is actually quite a small one, and this is the crucial one. This is respiration. So if you think back to Glenn's diagram right at the start, this is that air being exchanged into the arteries, the oxygen moving across that barrier in the alveoli. And this explains why, if you look at a blood gas, so some of you will be familiar with these, the PO2 is normally about 9 or 10 or 11 really, and that reflects the fact that by the time the oxygen has got down to the arterial blood, the partial pressure has knocked by about 10. So this is this difference of about 10's a useful rule of thumb to remember, because if you put a patient on supplementary oxygen, the inhaled partial pressure of oxygen will go up. So if they're breathing 100% oxygen, then in theory, the partial pressure is 100. And as a result, you would expect a much higher PO2 in the arteries, because that difference there is going to be the same, and we're just changing the amount that comes in at the start. I don't know if you can see my mouse, but I'm trying to demonstrate the columns I'm talking about here. Okay. The blood in the arteries has a reasonable partial pressure, but what you can see is that by the time the partial pressure of oxygen drops right down. And so by providing, I've just been told my internet connection is unstable, so apologies if you get a bad sound. I'll just recap. So by providing supplementary oxygen, we can increase the partial pressure at the start here, and hopefully we can therefore increase the amount of oxygen that gets down to the cell. Why is this important in COVID-19? Well, if you remember from Ed's talk yesterday, one of the key points I took away from that was that the type 2 pneumocytes were the cells in the alveolus that were affected by COVID-19. And when they're affected by COVID-19, they create some of these pro-inflammatory markers. And one of the effects of those is to increase the amount of interstitial fluid around the alveolus. And that increases the distance that the air in the alveolus has to travel to diffuse into the blood. And that therefore impairs this step here, and you're likely to get a bigger step in the partial pressure as you go into the arterial blood. So this is why supplementary oxygen is really helpful for these patients, because what you can do is you can increase the amount of oxygen on the left side of this and account for that big step that we're going to get if they've got damage in the alveolus. Okay, so we're just going to wrap up then. So COVID-19 and breathing, we're going to bring it back to a more clinical note. So clinically, coronavirus can present in a number of ways. It can make patients breathless, it can give them low oxygen saturation, so hypoxemia, and then it can cause respiratory distress. The reasons for this are multifactorial, partly due to ARDS. We're going to talk about tomorrow, spasm, secretions, and pulmonary edema. And these patients can also get pneumonias on top. Now, the reason physiologically that that's going to impair their oxygenation process is primarily because it affects respiration. And it does that by impairing ventilation, increasing airway resistance, so for example, the bronchospasm, impairing gas exchange, so that fluid in the alveolus, and sometimes impairing perfusion as well. And that's why things like proning can be useful. Okay, so let's just summarize. Oxygenation is that overarching process that takes the oxygen from the air and delivers it to the tissues via the blood. Respiration is the process by which the blood is oxygenated in the lungs. For respiration to work, we need good ventilation and good perfusion, and we need these to be equivalent and not mismatched. So you'll hear people say VQ mismatch. Ventilation is the V, perfusion is the Q. That's all they're saying. Coronavirus, we've said that respiration is the primary process that can be affected, and therefore some of the interventions and investigations like an ABG and then giving supplementary oxygen, assisting ventilation, these can be really useful interventions for these patients. Okay. So for some of you that will have been a lot of fairly sciencey content, some of which will be new in a short period of time, so that's probably the most technical of the talks from that perspective, so please don't be put off if you found it challenging. For others of you, it might be more of a revision, and if you want to dig a little bit deeper into some of this physiology, then the first link here is great for general physiology, but the second link, which is from the Physiology Society, explains some of the really specific coronavirus-related elements in much more detail, but it also really nicely uses pretty basic terminology and language, so it's very accessible, so I'd highly recommend looking at that.